All right, so like I always say, I'm Mr. Streb. I'm your content enrichment specialist for the advanced med surges, which is 265, 3800, 4100, things like that. So this week we're going over your class is going over nervous system and things like that. So there's a lot to get into. I know this already. So if you have questions, please ask. I'll start at 38 and we're just going to go down to Guillain-Barré. There's only really one thing in the whole chapter for 38 we need to worry about, in this book at least, and it's Guillain-Barré, right? We know that Guillain-Barré is it's somewhere in my book. Where did I just go? There it is. Okay, so getting into Guillain-Barré, let me make sure I'm in the right spot. 834. Why am I having a struggle? There we go. This book doesn't get into it a lot, but I want you to understand the same things. That what is Guillain-Barré? It's really an autoimmune response to, we just figured this out recently, the Epstein-Barr virus, which is the same thing that causes multiple sclerosis, right? Or if you start thinking about how COVID has changed people, COVID can make you have all kinds of autoimmune disorders. So that's what we know Guillain-Barré to be now. This is just very recent, like within the last year, they've discovered that Epstein-Barr virus is the one. So it won't be on any of your exams. But what is Guillain-Barré? And if you look at Guillain-Barré, it's a backwards paralyzation, if you will, right? So if you look here, you get a spinal cord trauma can also cause that. There's a lot of things that can cause it, but I'm just trying to make you understand what Guillain-Barré is, right? But if you had some kind of issue, that's where we'd be. So what does Guillain-Barré do? It's like I said, ascending muscle weakness. So it starts at your toes and it works its way up. So what are we really worried about? The same things we've been worried about with every patient we ever talk about, and it's going to be death due to respiratory failure. That's really what your focus is going to be on when it comes to your Guillain-Barré syndromes, kind of what that looks like. So just be aware that what kind of things are you going to be on the lookout for? Anything related to respiratory. So they might very well be on a ventilator. So you're going to have to think about what ventilators look like, and then kind of think about the hospital, the ventilator-acquired pneumonias, how we prevent that. The same things we talked about in respiratory already is kind of the same vein. It's the focus is where you have to be when you're thinking about Guillain-Barré, right? Why? Because we know the fine muscle activity is really what's affected first. So if you're thinking about signs and symptoms, if you're thinking about exams, if you're thinking about a patient laying in the room, what kind of stuff will you be looking for? It's going to be pretty subtle. So you're going to have them do some of the stuff we did in 242 or 170 when you did your head to toe assessment, the things we're supposed to do. So we're going to check for cerebral problems, right? So we'll have them run the heel of one foot up and down the shin. It's very much reminiscent of what we do for stroke patients. You're trying to check that really, really fine coordination to see if they're having any kind of muscle weakness or if there's a disconnect somewhere in the neurological path. So not that these will be on your exam for any reason, but I just want you to understand it's kind of the same vein in what you're looking at. It's still a neurological deficit, and we're trying to find motor responses, the fine coordination. So what are we worried about? Gait, equilibrium. We're worried about the patient's falling. So we need to make sure we talk about that, what it means to really be aware of your body position, be aware of your surroundings so you don't fall. Like I said, I don't have to get into a lot of it. Test questions will be very generic when you see them. Will they be on this so much? Probably not. If I keep thinking about Guillain-Barré, it's always going to be the same. It's about respirations. It's about the patient dying because they can't breathe. And then it's also risk for falls and things of that due to the equilibrium and the gait. And that's really it. That's really it for Guillain-Barré. I would encourage you to go back and look at this Glasgow-Coma scale while you're here, though, and understand what that looks like, because it's going to be used again as you start getting like TBIs and stuff of that nature. As your ICP goes up, they're going to do Glasgow-Coma scale. So if you don't remember what the GCS is, it's just a neuro check. And it's we just say, hey, are their eyes open? Mr. You okay? If they open their eyes, they get a 4. If they don't do anything at all, they get a 1. So a tree, a rock would have a score of 3, right? They would get a 1 for no verbal response. They would get a 1 for no motor response, and they'd get a 1 for never opening their eyes. So you can be from a 3 to a 15. Anything less than 8, we intubate. I just keep that on my hand because I know that if you ever see a GCS of less than 8 and you're thinking about any of these types of patients, I don't care what the cause is, intubation is probably going to follow. So I just like to give you that little tidbit because I know it helps, especially in real life. Cool. Anything we want to add there? All righty. So I'm just going to keep moving along until you tell me you need me to stop and clarify anything. So we'll go right into chapter 39, because according to your book, at least for if you're a 265 patient student, that's what we're kind of going over. So when we go to chapter 39, we're going over inflammation of the brain. So it's about 3 pages. It's not a huge chapter either. Trust me, we'll get into a lot more information as we progress through these chapters. I'm gonna hit the little stuff first, and then we'll get to chapter 40 and 41. And I don't think I'll be able to finish it all within the hour, because at 2 o'clock I have another session. So just so you're aware, I will do 2 sessions as needed. So as we're thinking about the central nervous system, it's really the same stuff. Your central nervous system controls your ability to breathe, your heart rate, your ability to eliminate. There's so much that goes on with your central nervous system. It controls all of your blood pressure. So if we can't control blood pressure, if we can't maintain the vessels, right, our arteries, if we can't keep those dilated or constricted as needed, it plays a huge part in perfusion. So we have to think about hypotension and lack of perfusion and what that looks like, a lot of cognitive changes based on that. So if you're thinking about this from a huge, 50-yard view of this, central nervous system, we're just talking about your inability to maintain any of that kind of stuff. So we're always going to worry about airway, breathing, and circulation. It's kind of the first and foremost of what's in my head. So we'll go on down to 866 to 869. Once again, your book told us we didn't have to look at this, so there's no point in us looking at it right now. If you're trying to go back and study, then of course there's other stuff. But like I said, going here and looking at what your syllabus says for 265 and 39, we're going to go over just the inflammation of the brain. So what do we mean by inflammation of the brain? Well, any kind of disease that can cause you to have an inflammatory response is going to cause what? What does inflammation bring? I'll let you answer that real quick. Inflammation brings what to that area?
Increase the pressure in the brain.
It does bring pressure. How does the pressure build though? What comes anytime there's inflammation? What shifts into where the inflammation is?
Can be fluid.
Yeah, fluids, absolutely. It brings in all the extra blood, because we need white blood cells. We need all kinds of stuff coming in when there's an infection to try to fight it off. That inflammatory response is going to cause swelling and just cause increased intracranial pressure. So I'm trying to get you to think of this on a big scale, right? Meningitis, any of these things, all they're going to do is cause inflammation. Inflammation is going to cause swelling and bring fluid, and that's going to lead to ICP. So a lot of this is going to look like just ICP. There's not much. It's hard to differentiate why somebody has increased intracranial pressure. Like, I'm not looking inside your brain. I don't know why it's there. ICP, increased intracranial pressure, looks pretty much the same regardless of cause, right? I think we can kind of agree on this. So understanding what you're looking for is going to be just a big thing. We're trying to really dive in and figure out why specifically is it meningitis. So if you're looking at an exam, AKA you walk into your patient's room, is that not the biggest exam you have? Right? You walk in, you're like, oh, I don't want to kill you. To me, when I say exam, that's exactly what I think about, right? So if I'm thinking about meningitis, what causes meningitis? Typically an infection. Bacterial, viral, those are the big ones, but it could be really anything. Fungal, it could be protozoal. I just focus on the bacterial and viral because that's really what we think about, right? What causes it? You could have a penetrating trauma, you could have a brain surgery, you could have an abscess that ruptured, whatever. You could get in a wreck or fall off of a ladder and hit the back of your head. What do you get? You get a basilar skull fracture. So we like to paint the picture. Why? Because you're going to get a patient history when you walk into their room, and then you're going to get signs and symptoms. You're going to have to figure out what you do with the patient, right? It's no different on the test. We're going to give you signs and symptoms that include things like a patient history. Like, your patient has a suspected basilar skull fracture. What would you be looking for? What would you expect to see? What would be an expected finding? Y'all hear those terms all the time here at your college, right? An expected finding or an unexpected finding. If you have a basilar skull fracture, what would you expect might be coming out of their ears and their nose? Should be cerebral spinal fluid. You don't want to see that, but when somebody has a basilar skull fracture, that's typically what we're going to see. So we're going to see that rhinorrhea. We're going to see discharge from their nose. We're going to see discharge from their ears, autorrhea, right? But what are we really looking for? We're looking for signs and symptoms of CSF. So you can do some kind of blood test where you can check for glucose because we know that there's glucose, right? And that's what we're checking for. Or you can do something as simple as a positive halo sign. Y'all have done that before, right? Where you take the 4x4 or 2x2 and you fold it up and dip it in some blood. Or you at least heard of that before? That the halo sign, the positive halo sign?
No.
Okay. You never heard that before? That's okay. So a positive halo sign. So if I were to look, I know I've read it somewhere here earlier, but I'm just going in my head here. When we think about cerebral spinal fluid and it's coming out, how do you know that it's cerebral spinal fluid versus just blood, right? So you, like I said, you could do a test to see if there's any glucose in it, like doing a point of care testing. And then we would also try to do, we might also do a halo sign where we take a 2x2, we fold it in half and we dip a corner in there. And as we open it up, if there's glucose, it will surround like a halo around the drop of blood. It's kind of a cool phenomenon. Go look it up on a YouTube video if you like. It's kind of neat to look at. But I'm saying these are the type of things that you can expect to see in real life, right? So I just keep going down. I keep thinking about other stuff like infections. What other kind of infections really might be something that indicates that you have meningitis? So if you have an ear infection, or if you have sinusitis, or you have an abscess of your tooth, all of those are portals into your brain. So it's very likely, I just want you to be aware of the stuff that might pop up. It could be something as simple as herpes simplex 2, varicella, chickenpox, shingles. Somebody has HIV. It puts them all at risk for like viral meningitis. I'm not going to beat it up. I just need you to be aware of what that sounds like, right? All right. Keep going down. So we know viral. We also have bacterial meningitis, usually caused by some kind of streptococcus pneumonia, right? Or the N meningitis. That's what we call it, because I can't pronounce the word anyway. So when we think about N meningitis, what are we talking about? We're talking about a specific organism that kind of comes in, right? So sometimes we have to think about antibiotics and how we're going to treat this. But what I really want you to think about when we have meningococcal meningitis, it has a very high mortality rate within 24 hours. So we need to really start suspecting if our patient might have been subjected to this. How do we know? We know that outbreaks of meningococcal meningitis are most common in places where people are very close, right? Go back to COVID. We wear masks when we have COVID, so we prevent what? Transmission. We call it droplet precautions. So people who live in like college dorms, or if you're like me, I'm retired Navy, living in the military barracks, any kind of overcrowding, if you're in jails, anything like that where you're really, really close to people, puts you at risk for any kind of communicable diseases. It's kind of funny. People gripe and complain about wearing masks, but we do this all the time. So be aware in the history what kind of patients might be subjected to meningitis, because it's got such a high mortality rate. If we're not paying attention, we can end up killing our patients unintentionally, right? That's the part that I really want to impress upon students, is what we're trying to do. All right, so keep going down. As we're thinking about meningitis, there's not a lot you're going to do for it right away. You can keep looking at the key features here. There's so many things in these boxes. Photophobia, that sensitivity to light, that's always one of the things we hear about with somebody who's presenting with meningitis. Typically the age, people between the ages of 16 to 21. Why? Because they are the ones who have the highest rates of infection due to where they live. They're in college, they're in the military, things of that nature. There are immunizations for this. So it's important that we talk about the immunizations, and we'll look down at the CDC's recommendation later on, but everybody's supposed to get the meningococcal vaccine between the ages of 11 and 12, and then booster around 16. So are we going to talk about that on your exam? I don't ever know, but that sounds like something that could pop up, right? So be aware of who's at risk. And then some of the signs and symptoms that would really kind of clue you into, ooh, what's going on here, right? I don't know. Red macular rashes, always something to think about. A lot of them are just very generic to everything. So just kind of be aware of those. One of the classic signs, and I'm sure you've heard of this before, is something called nuchal rigidity, which is a stiff neck. It's a classic sign, but it's not as what did they say, prevalent as you would suspect. Really is kind of hard. So you might see, I always go to the same thing, fevers and chills, nuchal rigidity, temperature. That's why I highlight the same things in the book right here. I always highlight them because they usually do pop up on exams, because they do present this way. When they get to a hospital, it's typically when you're going to have the patient show up anyway. So that's what we're talking about. Assess the patient for anything, including ICP. We're going to talk about ICP later on and what those signs and symptoms look like. But think about what that means. Increased intracranial pressure. I have fluid in my brain. It could impact any part of my cognitive functioning. That's the first one. And then really anything pituitary related. So we know a lot of these folks are going to have excessive vasopressin release, right? So excessive vasopressin resulting in water retention. So we think about SIADH. We think about the serum potassium levels getting low. Just things to think about, because signs and symptoms are what they're going to put in the stem of the question. And from that signs and symptoms, it's going to be your responsibility to understand what the treatment is, what the patient has, and what we're trying to do to prevent it. So I do want to talk about one more thing here, because your book mentioned encephalitis, right? So we know that meningitis is oftentimes misdiagnosed as encephalitis. If you remember encephalitis is, we're talking about inflammatory response in the brain, right? So there's going to be like an infection or something that goes in there and causes, I don't want to say an infection. I think about when you go into liver failure and you have all those byproducts and it starts with third space and it gets into your brain. We think about, you know, encephalopathy. So encephalitis, I start thinking that same vein. So an infection that goes viral, gets into your brain tissue. I just need to put it out there. These people might also present with fatigue, and you know, patients with encephalitis may present with fatigue and light and noise sensitivity, and they might have pupil changes, you know, decrease in size. It looks a lot like meningitis. So if you're not paying attention to both of them, they're not really trying to figure out what the patient has, then that could be problematic on an exam, just so you know. So how do we care for patients with meningitis? Well, the first thing we need to do is probably prevent them from making other people sick, right? What kind of precautions do we put people on who have, what do we put you on if you have meningitis? What kind of precaution is that for meningitis?
Droplet.
Yeah, so we definitely put people on droplet precautions. That is a big thing that we do. And then, so we'll talk about that a little later on in the chapters. Saying that you put somebody on droplet precautions who have like meningitis, right? Because it is a droplet precaution. The only thing that goes on, do y'all remember what goes on airborne precautions? There's only like 3 real diseases. Do you remember what they are?
MTV.
MTV, measles, tuberculosis, varicella. Yeah. And when I say varicella, I mean like herpes. There's herpes, you know, zoster, chickenpox, that kind of thing, just to keep your mind going. There's also smallpox, but we don't really talk about smallpox. So for the most part, if it's not MTV, it's going to be droplet. So when I think about these patients, and we went back and talked about them already, people overcrowding college dorms, military barracks, crowded living like prisons, they are the ones who struggle the most. So keep those things in mind, droplet precautions, staying 3 feet away from your patient, how to teach that to not just, you know, family members, but also other people who are caring for the patients on the care team. So, like I said, there's a lot to think about. As the intracranial pressure starts to rise, it is going to impact your pituitary gland. And I'm telling you, that is a lot of the stuff we see right here. I'm just saying inflammation, infection, expressed the cerebral cortex, blah, 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 excessive amounts of antidiuretic hormones. Vasopressin are produced. Why? Because it's impacting that pituitary gland. That's why I think about ICP. Any one of these disease processes can cause your brain to swell. It all looks the same when it presents as ICP, because it could be ADH, it could be diabetes insipidus. It just depends on how it impacts, you know, either the pituitary gland, the pineal gland, whatever it is in the brain there. Kind of fascinating, right? And then, like I said, encephalitis kind of does the same thing. So they prevent very much the same. How do we do a diagnostic test? So it says the most significant test used for diagnosing meningitis is what? Cerebral spinal fluid. How do you think they get that out of your patient? A lumbar puncture. So it might behoove you to know what that looks like. I don't think our book goes into it very much. I doubt you're going to be tested on that. It's more of a practical skill. But, you know, I had lumbar puncture once when I thought I had meningitis, and I couldn't, my foot wouldn't flex. I couldn't dorsal flex for over like 30 days. I thought I was going to be permanently disabled. But, you know, that's what spinal shock kind of is. It caused my spine to get inflamed. It caused inflammation. It pushed on some of the nerves, and I just could not dorsal flex. Fascinating, scary, did not like it. All right, so keep going down. I really want you to think about what your job is for somebody who has meningitis. So what does that look like? We're talking about inflammatory response of the brain. It's causing increased swelling. and it's impacting everything. Big things that we always talk about, you need to reduce ICP being the big thing. You want to decrease the pressure in the brain, because if we increase the pressure in the brain, what are we really worried about by increased pressure in your brain, in the circulatory system? We're going to pop a clot basically, and we're going to have a stroke. That's what we're thinking about. So we don't want to have so much pressure. We have a hemorrhagic stroke, and then we bust the vessel open, and then we bleed into our brain. So a lot of things are maintaining bed rest with the head elevated 30 degrees, not too high. And we're going to get down and look at ICP later on. But when we're thinking about meningitis, we elevate the head of the bed about 30 degrees just to keep the pressures where they're supposed to be. Provide that quiet environment. Don't overstimulate with noises and lights. That's always something we talk about with meningitis, because as we do, it increases pressure as well. All right. Moving down, this is what I was saying. Prevention of meningitis is a big thing. Think about the vaccine. Think about your H influenza, pneumococcal vaccines, mumps, varicella, meningitis, meningococcal. All of those things are things we can kind of impress upon our patients, if you will. All right. So as you're looking at your patient, as you're walking into the room and you're checking them out, and you think they have a suspected diagnosis of meningitis, or they do have an actual meningitis diagnosis based on what the doctor says, the physician, whatever, make sure you're doing these neurological assessments at least Q4 hours. If you're not going to see those early changes. What are we talking about? Early changes. This is where you have to pay attention, right? What do we mean by early stuff? What are the things we have to worry about? So priority care, early neurological changes that show increased intracranial pressure. Decreased level of consciousness is probably the biggest thing you're going to see on a patient who has changes in the pressure inside their brain. And that puts them at risk for what? Seizure activities. So as I'm looking at this as a nurse, what do I really need to know? What do I need to see in my patient to understand if they're at risk for this? If they haven't, what do I need to be on the lookout for to make sure they're not having complications from it? And then if they are having complications, what can I do to prevent injury, or what can I do to reverse problems? That is all we're ever going to test you on, even in comp finals and in ATI and NCLEX, because everything's based off the NCLEX test plan, which is all about patient safety. So safety risk, fall risk, I put it over here on the side. Seizure risk, fall risk, safety risk, things like that, decrease the stimuli. All of these things are things you need to worry about as a nurse, because that's directly what you have control over. All right, I'll kind of move on from there. They talk about hydrocephalus. It's just, is another thing, other indicators of hydrocephalus. What is hydrocephalus? It's just excessive accumulations of fluid in your brain. So when we use that term hydrocephalus, I think a lot of people think of it as a disease process, but we're just saying excessive CSF in your the ventricles of your brain. So all it's saying is increased ICP, and there could be some urinary incontinence, which I'll talk about later on, but we're just talking about the level of consciousness. It has nothing to do with the actual, hormones being released. It's just level of consciousness changes. I know it sounds like a lot, but trust me, there's a lot more in the book if you read it by yourself. So I'm trying to hit the highlights of things that always pop up that are always important for you to know. Okay. There are things we're going to use as far as drugs. We don't get into a lot of drugs here, and I'll tell you why. If you go to the NCLEX test plan on the NCLEX website, it has a list of drugs. It has a list of lab values and stuff like that you have to know. We don't ever test on anything more than that because it's not need to know. So go back and look at your NCLEX test plan someday, especially as you're getting close to graduating. It's going to give you a good indicator of the things you really need to memorize and what you need to have right here in your brain housing group before you move on. All right. What else do I want to say here? If you're in close contact with anybody with meningitis, we already talked about this in 242 and 170 is the type of medications, but never forget the rifampin, the ciprofloxacin, things like that. People might need to be treated with these if they've been exposed to or around somebody with like H. influenza, meningitis, because that bacterial thing can be, spread quite frequently. All right. I already mentioned down here in the safety the safety priority box is that it is droplet precautions. So you have to think about what that means. Private rooms when possible. Stay at least 3 feet away from the patient unless you're wearing a face mask like COVID. If they're being transported, who should wear a face mask outside of the room? It's the same simple stuff. And I know it sounds simple enough, but we're going to continuously test you over these things because they are that important. Just because you can memorize the pathophysiology, if you forget to put a mask on your patient, you just spread the disease around the hospital, and now more people have it. So keep that in mind. I just want to keep highlighting things like that because they're never going to go away and they will always show up on exams. All right. So that's really it here. We're going to go in and look for other complications. I'll talk about septic shock and I'll talk about some other things like that as we move forward. But that's the gist of inflammatory responses in your brain. So any questions on what they're asking you there on those pages? I know it's a lot. I'm feeding you with a water hose right now or a fire hose and you're just taking it in. But the point would be that you can pause this and go back as you do your lectures and you're studying. This is another resource where you can be like, all right, let me pause with Mr. Streb. Okay, this is what my teacher said. This is what he said. This helps you refocus. My goal is to help focus you on important items because the book is too big. Like you can't know everything. These will really help you if you're in 265 for your exam. If you're in 283, I hope it's a good refresher on the stuff that you know already.
I just have a question.
Yeah.
For doing the diagnosis besides the lumbar puncture, we have to do blood cultures, right? So
yeah, so you could, yes. So when you first, the answer is yes, you will. When you first get a patient, they might start them with some kind of broad spectrum antibiotic, which they typically do until they get the results back and they figure out exactly what the primary,
cause is.
Causative agent. Yeah.
But we have to do the blood cultures before the antibiotics, right? Because if we do it after, it's worthless now.
Yeah, so that's always with every patient. If you're going to start antibiotics and you're looking for a specific antibiotic, you will always do your cultures prior to starting anything. Otherwise, you're going to destroy any back. The potential is you destroy it and you don't really have a better understanding. So yeah, I do skip those parts because I know we talk about that in like 242 and 170, but yes, it's an absolute great point. You always want to make sure you do that first. And here in the book, it does talk about that. And it does mention starting antibiotics and the need for a more broad spectrum first, and until you get to the more causative agent and then do very specific. Great point. All right. Let me kick on to the next one real quick, because as we keep progressing, it gets more and more complicated. I start with the little stuff first. Now that we're in number 40 here, we're going to go over number 40. Now that we're in chapter 40, what they want you to look at is spinal cord injuries, basically in ASL or ALS. I'll show you both of them. It starts kind of on 874 and goes down. They have them backwards in here, but let me just scroll down. We're talking about spinal cord injuries, right? We know what the spinal cord controls all your neurological function. So it depends on where you had your injury on your spinal cord. The lower it is, the less mobility, sensory perception, and problems you have with that. The higher up it is, the more problems you have with everything: mobility, sensory perception, cognition, and even immunity. So those things become problematic. ALS, if you don't know what we're talking about a neurodegenerative disease. It impacts the neurons in the brain and the spinal cord, and it makes mutations. So it's not like ALS. We're talking about ALS. I just want you to make sure you understand what that disease is. It just affects your neurons. So we're still talking about neurological functioning. And we'll even get down here and talk about autonomic dysreflexia, even though it's not on your syllabus per se, it is a huge concept. All right. I'll keep going the same thing. All of these diseases look pretty much the same. It even says here, multiple sclerosis often looks much like other things like this. It's hard for you as a nurse to differentiate on the cause that made your brain swell and all the signs and symptoms look the same, right? It just goes without saying. Why do we care about these individually then? Well, it just depends on what you're talking about. There's no treatment for ALS, and we know it's 100% fatal. That's pretty big to know. So if you have multiple sclerosis and you think it's multiple sclerosis and you're not treating it as such, it's likely that your patient could die. So just on that initial thought, I want you to be aware of what ASL is and kind of what it looks like. If I go down here and look between the two, if I look at ALS, patients with ALS, especially if you've had them for years, think about a patient. This is a chronic condition. The longer you have ALS, the longer you live with it, the more likely you are to die from it, right? Because you are going to die from it, but you have progressive muscle weakness. You have wasting. What else? Paralysis. All of this stuff leads to the same thing. We don't die from sitting still. We die from the respiratory problems, respiratory failure, the infection caused by the inability to expand our lungs. It's venous stasis. So we end up getting venous stasis ulcers and you get infections. It's not the immobility or the neurological deficit that kills you per se. It's everything else that goes along with it. Once you can no longer breathe, what happens? You die. So that's what we're talking about. That's why I put over here, if you think about a patient with a chronic history of ALS and they're readmitted for things like fatigue, or if they're having dyspnea, all the dysphagia, if they're having, abnormal reflexes and all this stuff, our priority is always going to be the same thing, respiratory failure. So it's as simple as it may sound. I love nursing students because you're going to be out there taking care of me one day, but y'all love to overthink and choose the biggest answer you can find. It is okay to say priority is respiratory failure because there's nothing more of a priority than you dying. So muscle atrophy, muscle weakness, twitching of the face and tongue, all of these things, dysphagia. I think about a patient who has ALS. What am I really worried about? Airway. So think about somebody, if they're eating or drinking, they start coughing or choking. That isn't a good indicator that maybe they shouldn't be drinking or eating anything, because when they aspirate that into their lungs and die, it's going to be a you problem because they're dead. So be aware of what it is you're looking for and how you're going to save patients and really try to avoid those bad outcomes. All right, so that was that for ALS. We can kind of move on from that. There's not going to be a lot on it. You can tell by the page numbers. And it's not a huge topic, but it's something you should pay attention to. All right, now we're going to get to some of the big stuff. And we're talking about spinal cord injuries. So you'll have quite a bit of topics from this portion here. So when we talk about a spinal cord injury, it can be complete, it can be incomplete. Either way, it just depends on where the spinal cord injury is. Like I said, the higher up in your spine it is, the more problematic it is, because it impacts your ability to breathe and function with your autonomic nervous system. That's what we really worry about. Did your teachers in your class, have y'all gone through any lectures yet? Have they really gotten into any of the do they differentiate between complete and incomplete, or are they just kind of moving on from there? Or do you remember yet? It's okay. It's going to be okay.
We haven't had a lecture, Mr. Strad.
Okay, no worries. So this is the first one because y'all had a test on Thursday, huh?
Yep.
We have a test on Tuesday next week. So I get it. We're starting early to get you guys ready. I don't think there's a real huge difference. You don't necessarily need to know the difference between complete and incomplete. If it's completely severed, there is no neurological connection between your brain and anything past that injury. If it's incomplete, you could have some. So you might not be paraplegic. We'll use some other words in a minute where you have weakness, right? But still the same thing. Loss of mobility, sensory perception, bowel and bladder control. These are the things that we're worried about. Why do we care? Because if you're immobile, we have to worry about your inability to move blood around. We have to think about the venous stasis again. We have to think about clotting, DVTs. We have to think about you getting pressure ulcers, not being able to breathe and expand your lungs like you're supposed to. All of these things just increase your risk of dying. We already know that if you have a spinal cord injury, your life expectancy already goes down. It's just the way it is because your body is not designed to sit there that way. So that's what we're looking at here. I don't get into the hyperflexion, the mechanisms of injury, but if you run your car into a tree, you get the forward force and you also get the backwards force. So you get hyperflexion, hyperextension. It's that coup counter coup effect where you kind of hit, your brain goes forward, it hits the front of your skull, then you go back, your brain comes back and hits the back of your skull. So your poor little brain is just hitting the front and back of your skull in some of these car crashes, right? That coup counter coup type of injury, if you will. When it does that, it also makes your neck hyperflex and hyperextend, which could cause the vertebrae to sever your spinal cord. So that's crazy. And I'm not getting to all the pictures because they're cute pictures though, aren't they? If you do a dive, I don't even know that. What I want you to understand is it doesn't matter what causes you to break your neck. When it breaks and you sever the spinal cord, if it's a gunshot wound, if somebody stabs you in the neck, if you fall off of a building, you're in a car wreck, it doesn't really matter. They all lead to the same thing. Just be aware that any of those could be in the test question stem to paint you the picture that your patient has suffered what? A spinal cord injury. Other parts after your spinal cord injury, the secondary part is the hemorrhages associated, the ischemia caused by the lack of oxygen because you severed it really high and you can't breathe now. Your diaphragm no longer works. Hypovolemia, why? Because when you go into neurogenic shock, you lose your ability to keep your vascular tone. So everything dilates. Isn't that what septic shock is? And I'm not saying these are the same, but hypovolemia is caused by that. It can be caused by a decrease in circulating blood due to neurogenic shock or something of that nature. Same thing with the lack of perfusion and then edema. So if you go down here, that's all they're talking about. Neurogenic shock is a loss of blood vessel tone. So you're going to have a hypoperfusion. Cardiac output will be decreased because the pressure is down and you're not going to be able to get a good stroke volume out. What else do I care about on this one? Oh yeah, the major causes of death. What do people die from when they have spinal cord injuries? Like I said earlier, usually pneumonia, septicemia, sepsis because you get this infection, you're not moving around. Pneumonia causes the infection. If you can't take deep breaths, if you have a mechanical ventilator breathing for you, like Christopher Reeves did, Superman, that's what ends up happening. So trauma, we know, is what causes most of the TBIs and spinal cord injuries. It's likely a bunch of young dudes because we're not real bright sometimes. I'm just playing. If you're a guy, you're bright. I'm just thinking things out loud. But traumatic brain injuries are typically caused by that. We know that veterans have a lot of these as well, but they have comorbidities like amputees and other type of TBIs and spinal cord injuries kind of all go hand in hand a lot of times. So understand that trauma, if you're thinking about who's at greatest risk, everybody, like young people, especially young men, they are very much risk takers. How do we prevent it? Well, we have to avoid tasks like that are high risk. So down here in this part, I talk about helmets and sports. Why? Because it always shows up somewhere. If you're doing anything impaired, if you're a drunk driver, if you're on crack, whatever, if you like to dive and jump off cliffs, you kind of get where we're going with. Just be aware of what type of patient might walk into your test room, right, which is your hospital room. Make sure you're reading, because there's a lot of questions that say, who do you see first? We love those questions. We'll give you 4 patients and one of them is related to the stuff you're going over and the other stuff's related to other stuff. And you're like, huh? They're hard questions, right? So that's where I want you to really start paying attention to the type of patients who are going to show up on your test or in your patient room. I've already talked about this. Airway, breathing, circulation is your biggest concern always, especially if you have a cervical spine injury. So C3 through C5, you know, that mid-range there, because C1 and C2, you pretty much just die, right? You lose your ability to breathe and you kind of die. C3 through C5, you can still kind of be alive, but it affects your diaphragm. So we might have to put the patient on, you know, mechanical ventilation. Don't be surprised if you're ventilating somebody. All right, 2 more things on this topic right here, and I'll move on. Spinal shock is something your book talks about. It's not the same as neurogenic shock. Spinal shock is when you're like what Lewis, like Mr. Streb, like I had. When I had my scare with meningitis, I really wasn't scared, but I went to the doctor and they had to rule it out. So they did the lumbar puncture. They caused some spinal shock or a spinal shock syndrome, which means there's some injury. There's a temporary loss of motor, sensation, reflex, autonomic function. Like I told you, I could not dorsal flex my foot for over a month. I'd walk and drag my foot on the ground because of that. So that's spinal shock. It's not the same as neurogenic shock. Neurogenic shock is when you're unable to maintain pressure. So typically, we'll talk about that later on. You're going to be hypotensive. You're going to be tachycardic and tachypnic, trying to kind of meet up that way. Well, yeah. All right. What else are we going to do? Okay, we can kind of move on from there. I got lost for a second. So make sure you're always getting your baseline. You need to know where they are, right? So sensory perception from baseline, and then we have to think about the dermatomes, everything above or below. So if I have a C5 injury, I have to think about what I expect my muscle, you know, the dermatomes to be. I need to think about loss of motor function and mobility. If you notice a decrease in mobility and you see decreased dermatomes, like the patient's being more flaccid and they're unable to move, that is a good indicator that they're having more problems maybe there's increased pressure, maybe that the patient might be at risk now for losing their airway. So rapid response, always keep this in your mind, is with these type of patients, there ain't nothing you're going to do when they lose their airway, because it is a neurological problem. So you don't want to be waiting around trying to do stuff if you're not really paying attention. So patients may have muscle spasticity. They could have reflex activity below the level of the injury. There's just a lot of things that we have to kind of pay attention to and really be looking for. All right, cardiovascular dysfunction. I know this is not your cardiovascular, but I want you to think about it again. If you start having problems with your spinal cord injury, what happens? So over here, bradycardia, hypotension, hypothermia, all of these can occur because of the loss of sympathetic input. So you have to be paying attention to things like their temperature as well. Pay attention to their blood pressure. These are all going to be used to give you good indication that your patient is either perfusing or not perfusing, right? So if you have a BP of less than 90, because you had a spinal cord injury, that means you're not perfusing. It's going to be worse. So it's not just going to be questions about that. You need to understand, patients could have these type of issues. Autonomic dysreflexia is a life-threatening condition that happens when you get stimuli that causes a really sudden shift in your sympathetic discharge of sympathetic hormones, basically. So think about your catecholamines, right? That's what I go with when you think about your sympathetic response. And that's your epi, your norepi, and things of that nature. So we have to be aware of these patients and what autonomic dysreflexia looks like, what the causes are, and kind of what the key features might be. So go down here and look down here again, sudden significant rise in your blood pressure. If I have high blood pressure and you think about bradycardia, they don't really go together. Profuse sweating. This is a big thing as well. Why? Because of that cholinergic activity. When we start thinking about how they look, goosebumps up and down your body, flushing of the skin. These are things I've seen associated with spinal injuries. So be aware that when you get a spinal injury, it is very likely that your patient is going to suffer from this autonomic dysreflexia. So you need to be over here and think about these signs and symptoms. They will pop up again. You need to make sure you understand severely elevated blood pressures can cause hemorrhagic stroke. So we have to think about our patients. Right here it says sudden significant rises in systolic and diastolic blood pressure. Throbbing headache. Oh, that's why we're worried about a hemorrhagic stroke. I keep trying to paint the picture for you. You're not going to treat every patient that comes in any way, because that's the physician's job. Your job is truly to pay attention to what problems exist with patients who have spinal cord injuries, and what you need to be on the lookout while they're in that bed for the next 12 hours, and what you need to do to ensure they don't get worse. This is what we're going to test you over every single time without question. So you have to be aware of what this looks like. You have to make the connection between, if I have a spinal cord injury, it's very likely that I'm going to have intracranial pressure problems. It's very likely I'm going to have issues with blood pressure, autonomic dysreflexia. I'm going to have issues with whatever the case may be. So be aware of other stuff. What other kind of stuff can cause autonomic dysreflexia? So we know it could be a head trauma or something like that, right? It can be, but most likely, most often it's caused by things like what kind of risk factors? GI, GU problems, vascular stimulation. I think about people who are constipated. If you have a distended bladder, remember when we're talking about the kidneys and we're talking about elimination. If a patient has a distended bladder, we worry about certain things. We worry about autonomic dysreflexia. If a patient has a UTI, if they have epididymitis, we're talking about inflammatory response around, the testicles, scrotal compression. If you have bowel distension because you have an impaction from constipation, they all start doing what? That vagus nerve can start getting agitated or excited, and that can lead to this autonomic dysreflexia. So it's cool to think about. It ain't cool if you experience it, though, or if your patient experiences it. So I just want you to be aware of how autonomic dysreflexia kind of presents. All right, let's keep moving down just a bit. There are things like prolonged impaired mobility, pressure injuries, venous thrombus. This is what I was talking about. These are the kind of things that are going to pop up and kill your patient. Venous stasis will lead to venous thrombo formation. So you will end up with a DVT if you're not careful, and you will have, you know, pressure injuries in stage 1 and 2 and 3 at some point if you're not really paying attention. You're not getting up and walking. So bone osteoporosis, so you got to think about bone breaks, and you have to think about fall risk now. I don't know where I just ended up yet, so I apologize, y'all. Here we go. And that is where we're at right now. So assess the patients for their reaction to the injury, provide opportunities to listen. These patients are going to have all kinds of mental health issues now as well, right? Imagine you went from being able to walk and you're a caregiver and you're taking care of your family to now I'm bedridden and I can't go to work anymore. Listen, talk about them, see if rehab's working. All of these things matter. All right, so moving on down, analyze cues and prioritize. What are we prioritizing? I just highlighted a couple things. Respiratory distress and failure is our biggest, most important thing we're looking out for. And then these cardiovascular instabilities. Think about shock and autonomic dysreflexia and how they impact your ability to perfuse the body. It's all about a hypoperfusion and stuff of that nature. All right, what else we got going on here? I'm going to get through the rest of this, and then, like I said, I'll have to leave. Whatever I don't finish, I will come back to. I've already mentioned some of the things. Make sure you're assessing your patient for breath sounds, especially if they're on a ventilator, and then think about ways to improve ventilator or decrease ventilator-associated pneumonia. Go back and think about your respiratory, how the head of the bed, things of that nature. I don't think that'll pop up on your exam, but in real life, when you're taking care of patients, it matters. A couple other things I want to talk about: maintain adequate hydration through IV therapy, oral fluids. We have to think about hydration because we're trying to maintain pressure as well. Make sure you're looking for manifestations, like I've already said, of cardiogenic shock. If you don't know what those look like, neurogenic shock, go back and reinvestigate what neurogenic shock looks like. It can happen, and it's something you need to be aware of. Know some drugs. If you don't know drugs, I'm telling you, you're probably going to miss stuff, right? Not know them in depth, but make sure you know the name, like dextrin. You know, what does that do? It increases capillary blood flow within the spinal cord. We're trying to prevent what? Hypotension. Atropine sulfate, what does it do? Atropine causes your SA node to fire faster. So we're trying to increase perfusion through prevention of bradycardia. Other hypertensive things like dopamine. We know that dopamine is a vasoactive agent. It can help with increasing blood pressure as well, because we're trying to prevent shock. What is shock? Shock is nothing more than a hypoperfusion of your organs. So we're looking for neurogenic shock. Neurogenic shock, spinal shock is different than regular shock. You know, most regular shocks have what? Just kind of depending on what's going on, but I want you to think about shock in that aspect as hypotensive crisis, and we're trying to do something to keep their blood pressure up so the patient can breathe. So indications of neurogenic shock: a pulse ox less than 95. They have systematic bradycardia, meaning they can't keep their heart rate above, I think it's around 50. And then hypotension with widening pressures, right? Widening pulse pressures. And we'll show you what the map looks like in a little while. I'm so sorry, my mustache is itching, and I apologize. Can't keep my hands off my face. All right, go back and look at automatic dysreflexia again. Make sure you understand why it's an emergency. Why? Because it can cause you to have a stroke, which would cause a brain bleed, and which would cause your patient to die. How do we make sure we prevent that? Think about it. Reduce potential causes of hypertension and causing autonomic dysreflexia. So be attentive to their bladder. Make sure there's no distended bladder. If they need a Foley catheter, we get the Foley catheter. If they need to be on some kind of medication to keep their bowels from being distended and being constipated, let's do that. Make sure we think about temperature and early signs and symptoms. If we don't look at these things and we're not aware, right? Reduce potential causes. I put it over here on the side for a reason, because those are things that always pop up. All right. If you have a patient in autonomic dysreflexia, raise the head of the bed immediately to reduce blood pressure as the first action. That's what we're going to try to do first. Then call rapid response. All right. I'm going to have to stop right there. And then when I start back, I will start back on the next week. I will start here on 882, and I will finish the chapter 40, and I will finish chapter 41 probably on Monday. So be looking out for that, that next session.